Dr. Samo and TechAmerica for inviting me. I'm basically your wet blanket for today. Many of you may not have ever heard of ASQ, American Society for Quality. It's a 70,000 member organization with industrial engineers, 8,000 of whom work in the health arena or are part of the health arena. The rest have something to do with it in a variety of different specialties. These are all the folks that keep the pilots running straight. They help the industry move good, and they help Ford build the car that probably will eventually be our doctor, given the intuitiveness of the technology that they do. Health IT is very important. I'm not going to argue with that. I'm not a technophobe. It's a necessary condition, I think, in today, but I don't think it's a sufficient condition. It can't cure our healthcare system alone. It can make it better, but there are fundamental flaws deep in the system, some of which you've heard about earlier from the senator and others that really may or may not lend themselves to health IT. Blumenthal said in 2009, health is the means, health IT is the means, but not the end to the solution. Ask any computer geek in this country what you get when you computerize or automate a flawed process. You get a flawed process going faster and nothing more. And we tend to focus, in medicine, we tend to focus on clinical things. There is probably, maybe now there are, but there are very few physicians or nurses that were ever taught how to operate a business, how to run how to supervise people, how to do the basic down and dirty kinds of things you've got to do when you run a people organization of any kind, whether it be manufacturing, sales, management, whatever. There are problems and flaws in other domains of healthcare. One of them is operational quality. We tend to think about healthcare clinical quality. I will tell you that no physician in this country made a conscious decision to cut off the wrong leg of any person. It's an operational issue. It isn't a clinical issue. We also have financial quality problems and performance problems, and those are beyond my ken. But the most important problem I think we have in healthcare today is culture. I work in the front lines with a lot of primary docs. That's why I've got this thing about patient-centered medical home. We're trying to transform what primary docs do. It's a reacculturation, similar to what Mao Tse-tung did in China, in many ways. It's a complete change in how they operate. And it's a complete disconnect between the way that most physicians were educated and what they're being asked to today. We need to fundamentally re-engineer the entire system from the ground up. We don't need to add technology. I think we do need to add it, but it's only an add-on, and it's going to change some of the fundamental things we do. But at the base, we've got to re-engineer the processes. And we've got to re-engineer, as the senator said, the incentives, which are every bit as important. And re-engineering as a concept is just beginning to become part of the toolkit of healthcare. You've read about Virginia Mason and some of the other hospitals that have done it. They've really gone out of their way to do something akin to what Toyota did. If you work in Toyota, you don't just know about the Toyota way of doing business and the culture. You believe it, or else you don't stay there. And Virginia Mason's getting to the same place. I mean, you've got to ask yourself the question, in today's day and age, why should 1 out of every 3 hospital admissions end with an untoward event? We then need to ask, we need to make process improvement as a concern and culture change part of the lexicon of healthcare. We need to incorporate it to some extent in the educational processes of our health providers, not to make them Six Sigma black belts or lean technicians, but to make them aware of it, just like we teach them how to know what an MRI is. We need to also better improve the culture of healthcare. As we adopt and implement technology, there needs to be a careful attention paid to the culture of people and culture in people. To develop and sustain a culture of continuous improvement is a real key issue. Very few hospitals and almost no doctors' offices have that's what we do. We go in and take a practice and try to have them adopt their own culture of continuous improvement, adopt their own core beliefs which drive them. People are driven and motivated by belief and understanding. That's the way religions have been doing it for years. And they're very successful in that. There's been a lot of work done recently to show that medical practices and other healthcare environments are complex adaptive systems. What does that mean? It means that in reality, technology is important in making change and positive change, but the relationships between and among people are every bit as important, if not more important. And there's significant work done by Dr. Arnetz at Wayne State University and Dr. Nunning at the University of Colorado to demonstrate that. In fact, in the recent work that was done with the patient-centered medical home, they found that the two most important things to a successful transformation of a medical practice into today's world were, number one, and foremost, was the ability of the practice to accept change. And that's, you have to work hard at that. You can go back to the mid-1960s, rather, where a guy named Eric Trist was asked by the coal industry to fix the coal production problem, and somebody had developed a real big machine that's longer than this room, put it in mines, and to start curving coal off the wall, and the production went down, not up. And what he said was, take the machine, cut it into little parts, and let teams of people work with it. Production went through the roof. And we're seeing some of that same kind of activity when you force technology into complex medical environments like ICUs and that sort of thing. We're a little bit beyond that, but we're still seeing some of that. We've got to, I can go into medical offices and see computers being used as flower placement places. That's not what we want. We want it to be used. And so the last thing I will say is that I think we're basically, and it was alluded to earlier, using computers for the wrong things are not the wrong things. We're using them not nearly to their capacity, although it was alluded to. Computers are great record keepers, no question about it. What they excel at, and what they can excel at, is helping put decision-making capability in the hands of the physicians and or other providers as they need it. There's a really interesting experiment going on in India right now, placing artificial intelligence computers in the hands of barefoot doctors in public health departments. And when it was the type of computer that it is was studied, it's a computer that system that starts with evidence-based guidelines, but then adds Bayesian math and statistical programs, so that every time a patient is entered into the system, it updates the decision-making capability and becomes a continuously running clinical trial. When it was tested against internists with 10 years of experience, they tied. So try to put that into any internist office, doctor. I don't think many of your docs would want that kind of.
Absolutely not.
Right. So we're far away, but thank you very much.